Hello, everyone, and welcome back to Echo Asthma Bootcamp. My name is Ashley. I'm your facilitator. I'm joined today by my coordinators, Rachel and Tabitha, our wonderful hub team, Dr. Meredith McCormack, Dr. Lewis Kurtzky, and Andrea Jensen, certified asthma educator. All right. Hi, everyone. So now let's get started with our third lecture on endotypes and biomarkers hosted by Dr. Care.
So in today's session, we'll talk about endotypes of severe asthma and biomarkers for severe asthma. So this is where we ended off the last session. The reason to recognize your patient's phenotype is to really attempt to use the phenotype to understand the underlying pathobiologic mechanism or the endotype that would then allow us to select appropriate treatment. And the way we do this in severe asthma is by using a biomarker. And so there are two main inflammatory pathways or endotypes that exist in severe asthma patients. There are two distinct pathways, type 2 pathway and the non-type 2 inflammatory pathway. And it's really important to differentiate between these two because as of mid-2020, biologic medications are approved only to target the type 2 pathway of asthma. And biomarkers can be often used to establish a baseline, guide an appropriate choice of treatment for these patients, and in some occasions monitor progress to see how they respond to the drug. Before we jump on to biomarkers, let's talk about inflammation in severe asthma. Type 2 inflammation is represented on the left side of the screen. Allergens and antigens is what often triggers the cascade. Thymic stromal lymphopoietin, or TSLP, is one of the early regulatory mediators that stimulate the Th2 cascade. The Th2 cell produces interleukins 4, 5, and 13. IL-4 triggers then the B cells to produce immunoglobulin E and ultimately triggers the mast cell for production of other substances downstream, such as histamine, leukotrienes, prostaglandins, and other interleukins. IL-5 is extremely important for eosinophil stimulation and sustenance. And a lot of the inflammation we see in type 2 asthma or type 2 inflammatory asthma is associated with this eosinophilic inflammation. On the right side of the screen is non-type 2 inflammation. This often gets triggered by exposures to irritants, pollutants, microbes such as bacteria or viruses that creates a series of downstream cascade that triggers the Th17 and the Th1 cells to produce additional molecules. Ultimately, the common pathway for both type 2 and non-type 2 inflammation triggers asthma and causes hyperresponsiveness, remodeling, a lot of mucus production, and smooth muscle hypertrophy or constriction, which is ultimately what happens in asthma to cause symptoms. What you see here are the different phenotypes and different inflammatory cascades. On the y-axis is the severity, and the x-axis is the age of onset. If you look at the bubble of type 2 asthma or Th2 asthma, these can be both mild asthma, such as exercise-induced bronchospasm, or it can be quite severe type 2 asthma, such as aspirin-related disease, late-onset eosinophilic asthma, or certain types of allergic asthma. Most non-type 2 asthma, however, tends to be adult onset and more likely to be associated with obesity. Late onset, particularly in women, can be associated with smoking, in which case it's more neutrophilic, as well as this concept of quasi-granulocytic or non-inflammatory asthma. So let's review the main points about how to differentiate type 2 or Th2 high asthma from non-type 2 or Th2 low asthma. Type 2 asthma tends to have a lot of airway and systemic eosinophilia. They're often responsive to both inhaled and systemic corticosteroids. They're responsive to inhibitors of type 2 inflammation. And the predominant interleukins on this side are IL-4, IL-5, and IL-13. For non-type 2 asthma or Th2 low asthma, it's often represented by absence of airway and systemic eosinophilia. They may not be, or maybe less responsive to steroids. Currently, we do not have an FDA-approved drug available to manage patients with non-type 2 asthma. And these are the interleukins that are mainly associated with non-type 2 inflammation, such as IL-6, 17, 8, interferon, and TNF. And so these are some of the biomarkers that are currently available for helping manage our patients. Blood eosinophils is easy to get. You can routinely obtain a CBC with a differential count or specifically ask for blood eosinophil counts. It can be used to assess if your patient qualifies for anti-interleukin 5 treatment. And we'll talk about it at a later session. The limitation for this is that fasting, obesity, and adrenal activation can all fluctuate eosinophil counts. It's particularly important that when a patient is on chronic steroids or has been exposed to a recent course of systemic corticosteroids, that may actually mask eosinophil levels and needs to be considered when an eosinophil level is checked. Sputum eosinophils can be checked. These are not routinely checked in clinical practice because techniques are not necessarily standard. They're cumbersome, but certainly there are research studies and protocols that use sputum eosinophils routinely, and they can accurately predict response to inhaled corticosteroids. Fino, a fraction of excreted nitric oxide. These tests are easy to perform. They're often bedside or point of care tests, and they can track closely with sputum or blood eosinophils, and they represent airway eosinophilic inflammation. However, the American Thoracic Society Fino-guided treatment algorithms have really not helped outperform symptom-guided plans. And then finally, immunoglobulin E. Again, a blood test can be used as a surrogate marker for atopy, and patients with high IgE can be identified to see if they would benefit from treatments such as omalizumab. These levels of IgE decrease with increased age, regardless of the patient's type 2 status, and levels usually poorly predict response rate to omalizumab, and usually we don't necessarily track these patients with IgE once a patient is started on omalizumab. So how do we put all this information together to really personalize the treatment for our patient with severe asthma? So this is the way I approach a patient with severe asthma. We do a dedicated phenotype evaluation followed by a biomarker evaluation, and then we put the two together. So to review for a phenotype evaluation, you really want to get an appropriate asthma history. How old were they when they first started having asthma? Do they have a strong family history? How's their asthma control? Are they high healthcare utilizers, or is it well controlled? Do they have frequent exacerbations? What is it that triggers their symptoms or exacerbation? Is it allergies? Is it more infections? Is it more exercise? Is it aspirin? What is their exacerbation history? How many steroid bursts they get in the last year? How often have they gone to the emergency room? Have they ever had an intensive care unit admission? And then understanding what their comorbidities are around reflux disease, obesity, sinus disease, sleep apnea, recurrent respiratory tract infections, and then associating all this information with the spirometry. Do they have normal lung function, or do they have obstruction on their pulmonary function test? Do they have fixed obstruction on their pulmonary function test? And then once we know their phenotype, understanding what their biomarkers is to try and understand what is going on in their body and linking it to an endotype or a type of inflammation. And this can be done with the help of an allergy test to see if they have a positive allergy test or allergic asthma, an immunoglobulin E or an eosinophil count check, and a Fino may be checked as well. So once we have a phenotype and a biomarker, how do we put it together to identify treatments for our patients? So for patients with allergic phenotypes, these are patients who, again, to review from the last session, are early onset. They may develop asthma as a child or as a teen. They're often triggered by allergies, have a seasonal variation to their symptoms, and have a strong family history. For the biomarker evaluation, they will have a positive allergy test or some sort of allergen sensitivity and a high immunoglobulin E level. They may or may not have eosinophilia. And these are the patients who will respond well to omalizumab, which is an anti-IgE monoclonal antibody. For patients with eosinophilic asthma, these are late onset with a lot of comorbidities such as sinus disease, nasal polyposis, and aspirin sensitivity. They tend to have frequent exacerbations and healthcare utilization, and may even require oral corticosteroids for maintenance therapy. These are the patients who an eosinophil would be checked, and if it's elevated, whether it's in the blood or the sputum, would qualify for multiple drugs that are now available by the FDA, such as mepolizumab, breslizumab, enralizumab, and dupilumab. Again, these are all the drugs that are available for patients with type 2 asthma, and we don't currently have an FDA-approved drug for patients with non-type 2 asthma. Thank you for listening and for your attention, and we'll open this up for Q&A.
As always, thank you, Dr. Kerr. Thanks, everyone, for listening. Dr. McCormack and the rest of our hub team, what are our key takeaways from this lecture?
This is a nice follow-up from last week when we talked about phenotype and really endotype being the biologic underpinnings of what we observe clinically in the phenotype. And so some of those categories which were described being IgE, eosinophils, non-invasive markers of eosinophilic inflammation in the upper airway with our Fino, and thinking about, and as well as allergy testing, RAST or skin testing, as ways to really support what we're seeing with our phenotypes by defining the endotype and really then classifying either a T1 or T2 predominant classification, which guides treatment.
Thank you, Dr. McCormack. Any thoughts from Dr. Kurtz Scheme?
Yes, I do have a couple thoughts, but I can't say they're very illuminative, because what we just saw on the slide looks really easy and it looks really obvious, but that's not been my life experience. Instead, people can have type 1 and type 2 asthma, and the picture is not always distinct. And we do clinical trials, for instance, and show that biologic intervention is of particular utility in the persons with the most distinct visible characterizations as one class or another, but we still have responders and people who aren't in that class. I think what we're striving to do is something that is noble and is valuable, because when I looked at the data in the last few years on how many patients with asthma had actually had allergy testing, it was only a small minority. And if this discussion about the necessity to establish phenotype and endotype will just lead clinicians to think more often, is there another underlying reason why my patient's asthma is not well controlled? That alone will be a success, because we have too long thought of asthma as a disease where what the clinician needs to do is simply open those closed airways. And that made our thinking quite simplistic. Well, then the answer is a bronchodilator. And we would just stack various bronchodilators on top of one another and wonder why we didn't get success. So I think this discussion of seeking to make a better foundation for whether our patient is type 1 or type 2 or both is a noble one. But I think we still have to be wary that that's not going to answer all of our problems, and there are going to be people who don't fit any convenient characterization. I do a lot of education on COPD, and it was quite dismaying to my colleagues in primary care who thought they basically understood COPD, and then they basically understood asthma, and then someone talks about, well, actually there's a new category, ladies and gentlemen, COPD asthma overlap. And what are we supposed to do with that? So I'm glad we are searching for better identifiers that will help, especially to receive better improvements in people with classic categorization. But I don't think it's always so clear as it looked on that slide, where people fall neatly into slot A or slot B.
Thank you, Dr. Kurtz Scheme. Let's see, we have a couple of questions. I think we should probably get to these. We always have such wonderful questions from this group. Lisa asks, to assess biomarkers, what would be the suggested wait time to assess blood eosinophils after a course of systemic steroid?
I think there's probably a lot of variability in that. So I would say at least 2 weeks, I would expect the eosinophils to be suppressed, and maybe longer. But if your patient's starting to have increase in symptoms, in part I would gauge by their clinical course. And when they start to have recurrence of symptoms, I'd be interested to track the eosinophil count at that point to see whether it's tracking with their symptoms. But if I were going to really try to reestablish, I'd probably wait even more like 6 weeks if if there wasn't kind of a need to test earlier, either because someone's having a clinical recurrence of an exacerbation or something like that.
And feel free to unmute, Lisa.
Yes, that definitely answered the question. Thank you.
Excellent. And then we have a question from Paul. Excluding Xolair. Oh, Dr. Kurtzke, please go ahead.
Yeah, I wanted to ask Dr. McCormack, if a person is anxious and wanted to determine the endotype more rapidly, could they use Fino in the meantime if they were on the fence and said, you know, I've been waiting for 3 weeks. This person had a long sustained course of systemic steroids. Since I can't really decide yet about the EOs, could I just use the Fino instead?
I find Fino to be a little bit messy. You could, and I don't think you would be like, if you have it at your discretion and the patient's there, like, if you have it available in your office and the patient's there, I think, and you're tracking that on this patient or other patients, I would certainly use it as a tool. But also if a patient's on inhaled steroids, that could influence their results as well. But then again, if they're always on inhaled steroids, and then you're kind of looking for the effect of prednisone or Solumedrol on top. So I think there's a lot of nuance in the way you might use exhaled NO, but I think if you have it available as a tool and you're using it for that patient or across patients routinely, then it certainly can be helpful. I actually like the fact that the eosinophil count is pretty easy to obtain. So if I had a patient in my office and I had an available blood draw and they were getting a little bit worse, I would get it that day if it was on the rise. And I was trying to evaluate, for example, whether they're going to really meet criteria stringently for a biologic, but they don't quite meet it on that 2-week point. I would just check it again at 6 weeks.
Thank you. So back to Paul's question, excluding Xolair, how do you choose your biologic agent?
That's a great question. And now most of the biologics are the ones that are not Xolair but acting on the T2 pathway are available for home injection. And so for a while that kind of happened one at a time. So now that the majority are, that used to be a way that I would decide for a period of time, but now that's really something that's available for the most part across the board. One additional way is whether there are comorbidities that a patient may have. For example, if someone has nasal polyps or upper airway disease, dupilumab may be a good choice as well. For patients that are more rare but have, for example, ABPA, allergic pulmonary aspergillosis, bronchopulmonary aspergillosis, mepolizumab is approved for that. And so if you have a secondary indication, you can kind of look to each agent to see whether atopic dermatitis is another one, whether they would meet criteria for 2 reasons. That's rather rare. And so I think after that, it may be personal preference or experience what people are more used to using.
I don't remember the dosing interval for all the biologics, but doesn't benralizumab have the longer dosing interval? And for some folks, just the simplicity of only having to do it every 8 weeks over a long interval instead of every month. I've looked at this phenomenon that simply having to take medicine, whether it's pills or patches or injections, every time a person has to take a medicine, they have to re-recognize, I'm not a well person. And so there's a lot of people who really like the idea of the least frequent administration of medicine is enough to actually turn the switch of even a price differential. If they said, I'd much rather take something every 8 weeks than every 4 weeks, then I can certainly respect that. But I don't know if there's any evolving treatment schemes that are equally able to spread out the other dosage, or is there a distinct difference in the interval? And I work in a setting called an FQHC, that's a federally qualified health center. So we have a very low resource population dominantly. So I don't have a lot of experience with these agents specifically because of the cost prohibition. So if Dr. McCormack or Andrea could assist us in, does the dosing regimen make any different for the parenteral treatments? I'd appreciate the help.
So that is such a great point. And I have had different experiences. Some patients actually kind of prefer a more frequent dosing, and then other patients feel much more strongly about a less frequent. So that's a really great point. And I think a lot of it is individual preference. I agree. Our office we put a lot of resources into getting these medications approved. And we have a fairly specialized practice. And so I think that's certainly can be a heavy lift to go through the administrative hurdles that are needed. And those seem to be changing over time. So hopefully it may get easier. You mentioned dupilumab is every 2 weeks, mepolizumab is every month, and then benralizumab you start with every month and then go to every 8 weeks. Not that anyone needs to remember that. You can look all those things up. But and then reslizumab is an infusion, so that's I think less frequently used. But those other 3 are all available at home, and at least for our patients now, they just get shipped directly to their home. So even though I'm in an area, I work in a city, so people are not as geographically spread out as they may be in some places, but still people have hurdles for access to transportation and so forth. And so that's actually gotten a lot better lately, that patients are able to get the meds delivered to their home. I can't speak to how that works in very rural areas, but that's been less of a hurdle. But certainly the dosing interval is something to consider, and you can just look that up. It's people have preferences typically, and they're not always as you might predict.
Yeah, that's a really interesting point. And to add to that, I have a colleague here at the health department, and she said that she switched biologics because she noticed when she was on Fasenra, she said when she felt like it was closer to the time for her next dose, she just started to feel awful. She could feel a difference in her lungs, and she felt like she needed to be on something that was a little bit more often. And so I know we'll talk about this in a couple of weeks about shared decision making, but I think really getting that input from the patient as how are they feeling, and are they feeling like it's working? Are they noticing a difference? Because there are so many variables with asthma. It's so tricky. Just when you think you've got one person figured out, another one comes along and you have another tricky person. So hard, really hard to do.
Yeah, I think your comment is right on, Andrea. There's a parallel experience we have in midlife and more mature men who get testosterone replacement. It's parenteral, and you can give it weekly, 2 weekly, or 4 weekly. And it is not the blood that turns out to make the choice. It's how the patient feels. Some men feel like they're back to the way they want to be when it's given to them once a month. And other men said, no, I used to do it every week, and now I'm going every 2 weeks. It's not enough. So I think your comments are listen to the patient, make sure their control is good, or look at their metrics. It's not what it necessarily says in labeling that should define whether the patient needs the longer interval or the shorter interval.
I think that's a great point. I've also had that experience where some people say they feel like they can feel sort of the effects of that plateau. I think Paul asked about switching biologics, which is a great question. In our group, we actually had a conversation about this on Monday where we were sharing our experiences with switching. And I think that's also a really important point where primary care and specialty care can have crosstalk as well. One thing, I think most people will feel and appreciate an effect in about 3 months if they're going to have an effect. But one thing that can be tricky is if someone stops a biologic early, like after 2 months or even after 3 months, and then they switch to another one. And then often someone like that might come to my practice. So now they've been on 2 biologics, but I wasn't the person caring for them. And I believe them, but maybe you don't have as much objective data. And also asthma's a disease or a condition that varies over time. It has seasonal drivers, other things that aren't even seasonal, just environmental triggers, life. And so because it tends to vary over time, trying to understand an effect of an intervention, I think takes just a little bit more time. So when we were kind of talking about this, we were saying it's nice when someone's been on a biologic for 4 to 6 months, like maybe ideally even 6 months before they switch, just so you can feel really confident if you think that medication didn't work, that you've given it a good try, and now it's kind of, something that you're probably not going to revisit. Otherwise, it can get tricky if you're bouncing between meds and then there aren't so many to choose from.
Yes, remember if a patient is given an inadequate trial to drug number 1 and you start biologic number 2, they have the beginnings of the cumulative benefit of the drug they thought failed. Now they go on the new drug, and the new drug is really just adding on to the achieved benefits of its predecessor who was accused of making a failure. Being involved in general medicine, I can assure our colleagues, I don't know what spheres of medicine our colleagues in line are on. I know of no class of medicine where intra-individual variation hasn't played a role and does not appear in the literature. For instance, there's a trial in depression called the STAR-D trial, like stars in the sky and D like Denver. And what they did was sequential treatment with antidepressants. And they found out only about 30% of people who are depressed respond to the first agent. The second agent, even from the same class, you go from SSRI number 1 to SSRI number 2, about 30% of those people will still succeed with the drug from the same class. Same thing is true in triptans for migraine. A person who didn't respond to the first migraine, triptan, you don't say, oh, they're a triptan non-responder. There's a trial in rheumatoid arthritis using NSAIDs. There is no explicable reasons why nabumetone should be better than ibuprofen, should be better than Voltaren. But in smorgasbord blinded trials, people have very definite preferences that apparently are based upon the chemistry of that drug within their body. So I hope that what we can look forward to is that we won't misclassify a person as a biologic non-responder simply because they had tried one example of a defined class.
Thank you, Dr. Kurtz Scheme. And Paul notes that these therapies are not initiated quickly due to insurance approval. Yeah, that's something that we definitely talk about, I feel, at every turn, which is a shame. But later on in the series, we do try to work with managing the injectable medications. And, obviously, of course, Andrea has given us many links and resources that are in our resource hub right now. If there's something that you need to check, today. So please visit the resource tab if you want to take a look for any of that. Well, thank you everyone for your questions. I think now we can get started with our case presentation by Dr. McCormack. Dr. McCormack, would you like to share? I can do that as well. It's completely up to you.
Why don't I try sharing? We'll see how that goes.
All right, you got it.
So this is a patient that I saw who was younger than many of the patients I usually see. She was 20 at the time, and she had developed symptoms of asthma in sort of late elementary school. She had presented with cough. She had shortness of breath, chest tightness. She especially noticed shortness of breath with exertion. And in walking, she was on a private high school campus and walking back and forth. She felt like she was even walking where she had previously participated in sports more. She was noticing these symptoms. They were pretty much daily and also impacted her sleep. She had undergone RAS testing, which I'll show you in a minute. So not allergy skin testing, but she had undergone testing to try to understand her allergic profile, and didn't have any allergy symptoms specifically at the time when I first saw her. She did appreciate improvement with albuterol, and she definitely appreciated improvement with steroids. So she had been on multiple doses of prednisone that had been prescribed. Actually, one had been prescribed by a neighbor who was a physician. And that part of how she got to my practice was this neighbor had prescribed her prednisone because she was really doing very poorly, and then just had done this several times and then said, you have to get into a better care model here. She described that she had been vaping, which was fairly recent, and I'll come back to that. She did have, would notice that she felt like she had allergic symptoms when she went into her friends' homes that had pets, and that cold air, particularly exercising in cold air, was a trigger for her. She was on salmeterol fluticasone at higher doses, 500/50, and prescribed as 1 puff twice a day. But she was not taking that regularly. She was also on montelukast and took that a little bit more regularly, and was using her albuterol quite frequently. I did have concern for medication adherence, and she was very forthright that she didn't use it very frequently or use it kind of haphazardly. Her asthma had resulted in her missing school and really had less physical activity. And she also really had stopped participating in sports. And so it seemed like this was having quite an impact on her life. She didn't, I put yes for this sort of ER urgent care visits, but these were really done, had been done a little bit informally by this like family friend who was a physician. And so that, and she had been prescribed prednisone in that setting. Kind of part of that real world doesn't always read the textbook of how things should ideally go. She did not smoke cigarettes, but she did vape, and she had picked up Mango Jewel recently, and had, by the time I saw her, was juuling a pod a day, and really felt like it would be very hard for her to quit this. She didn't smoke anything else. She didn't smoke marijuana, and she didn't use any drugs, and she didn't really have. Otherwise, she was didn't have any major health issues, with the exception of she did have anxiety and depression that had been pretty significant, and she had required inpatient treatment at one point in the past, and was still working on those medical issues. Just scrolling through our form here. So that was kind of in this bucket. And then otherwise, she didn't really have any other medical problems. She, I went back when I was looking to put this case together, and this is one of her white blood cell and CBC. She had this, on this test, she had 13,000 white blood cells, and her eosinophil count was over 1,000. She wasn't anemic, she had normal platelets. Her IgE was slightly elevated or somewhat elevated. And this was the results of her RAS testing were demonstrated positive results to Timothy grass, oak, maple, and English plantain. So grasses, trees. Her lung function testing, she had she had a pretty extensive workup. She had a cardiopulmonary exercise test that didn't really reveal any abnormality. And she also had spirometry that showed mild airflow obstruction with bronchodilator improvement of 18%. She had a normal chest x-ray, and when I examined her, she had wheezing that was audible, particularly in the expiratory phase, throughout all of her lung fields. Otherwise, her exam was unremarkable. So she came, the initial time she came with her parents that were worried about the fact that she was requiring prednisone. They wanted to know if she was a good candidate for biologic therapy, and really what we could do to get her sort of back from her current state where she was during this time. There are a few points I wanted to make, but I was hoping to just engage a little bit in discussion about what some of the things you might start with, knowing what I've just told you. And I'll summarize a little bit. This is a young woman. She has a history of anxiety, depression. She's been treated in the last year. She's had frequent exacerbations of asthma that are pretty much a new feature of her asthma. She's not very adherent to her ICS/LABA therapy. She's juuling, and really this, her asthma has really become quite problematic, I would say, in terms of her ability to just function in her life as a student and as an adolescent, early 20-something. And so sort of what would be the first things you might do? And would you now think about a biologic, or what other things might you think about first? I think was kind of the nature of the question.
Paul in the chat said optimize therapy first, HFA versus DPI. And just so everyone knows, feel free to unmute yourself and chime in if you have something to add.
Yeah, just as a general thing, I think this might be an example of just going back to classifying, is this severe asthma or is it uncontrolled asthma, or could it be a little bit of both possibly? But definitely, like, first, as Paul had mentioned, optimizing therapy and getting it under more long-term control, so that hopefully, and just educating with the family, like, okay, well, even though going on prednisone is a big deal, that it may not necessarily mean that she requires the biologics. Maybe there's other things to be done first.
Thank you, Nora. Yeah, and Rick, I know that Rick won't be won't be speaking to us, but the vaping really sticks out as worrisome, especially at the age of 13. And Shrikala also echoes to optimize therapy.
One thing I would look at first is the Montelukast, where we know there's a black box warning on that for some of the psychological effects, and where she was actually inpatient. I mean, she kind of went beyond depression and anxiety and was actually hospitalized for that. So for me, I think that would be a great thing to take her off Montelukast and either have her, doing Flonase or Claritin or a number of things. And then the other thing is, I was thinking it's motivational interviewing with her and saying, well, what is it that you can't do right now that you would like to do? And I don't know how many people are familiar with motivational interviewing, but really it's kind of guiding that patient to make the choices almost that you think would be good for them, but having it be their decision. So what is it that she can't do now? She can't be active. She can't do things that she wants. What does she need to get there? And what changes does she need to make to get there? And when I was looking at her compliance, I was thinking, would she be a good candidate to use a DigiHailer so that her parents or doctor, whoever, could actually track her compliance? Or would she be a good candidate for something like Brio, where she just takes it once a day? Lot of things to unpack with this gal here, but that depression and anxiety, and especially being hospitalized with that's we've got to deal with that, I think, before we can deal with the breathing issues, because that's controlling every part of her life. But yeah, this kid probably needs a social worker and a whole team that can work together for her.
Yeah, I agree with what everyone has said so far. What strikes me as a family medicine doctor, of course, we have a diversity of things to deal with, is this woman needs some structure. That someone has to sit down with her. Patients are innocent when they use what I call heritable antibiotics or drugs. Yeah, my Aunt Martha gave me some of her tetracycline, or my brother's a veterinarian and he gave me some of that. Those things that people do, they don't realize there's risk, and that by shortcutting and intervention for their health, they may be cheating themselves out of better definition of what's really necessary. So someone has to sit down with her and say, Martha, I don't know what her name is, but Martha, let's talk about what we think are the things that you can best put into a map to best manage your health. Here's what we need to know. You say you use your bronchodilators sometimes. You say you take your steroids sometimes. What do you think is the best plan? And using Andrea's mention about motivational interviewing, you want to find out where the patient wants to be, and then you want to find out from them, what is it that seems to be standing in their way? And what are they willing to negotiate to do to take steps to remove that? It is a sad day in America when, like the word Xerox, which started out as a noun and now has become a verb, the word jewel went from a noun into a verb already. So it is that commonplace that we have to deal with it. She might beg off on the jewel. There is scanty data that says that persons who want to stop smoking can use the vaping inhalers as a step to get off instead of using other versions of nicotine. But that data is very scanty, and the number of young adults like this woman who are beginning vaping and subsequently go on to cigarettes is higher than would have been there in the absence of the vaping, because last year in America, we had the lowest incidence of smoking in America in history, 13.5% of adults. Concerningly, again, as in this young woman, the average age of initiation of smoking in persons who establish a lifelong habit is 13 and a half. So people start very young. This young woman appears to be no exception. And there seems to be some ambivalence about clinicians who said, well, maybe the vaping will prevent people from smoking. And unfortunately, that has not been the case. I think we need to come to a consensus that you don't want to put anything into your lungs which has demonstrated toxicity, which this has done. You might have people, she said, well, I used to smoke. Isn't the vaping better for me? the vaping probably is better than cigarette smoke because the vaping doesn't have known carcinogens in it. We don't yet know whether the high pressure, high velocity vehicles that these kids are inhaling could cause cancer. We just don't know that. There hasn't been a long enough lag interval for us to learn the safety profile of vaping. But we'd rather, if these kids had to use some sort of nicotine, we would rather use a topical or a chewed version than this inhaled version if we can get away from it. So I think that this young woman needs is a structure to say, okay, what are you doing in your life here? What are you doing there? I know you thought the Montelukast helped you. Was there any association between that Montelukast and your emotional state? To what Andrea says, because we used to think of Montelukast as the safe person's way through asthma. We said, well, we always have this nagging concern about steroids. I have a patient and he has a son and his son has low stature and he's worried if I give him the inhaled steroid, you know, even though the guidelines said steroid, I'll do the Montelukast because it has no side effects. That we bought that as the free lunch. And now we're realizing, as in so much of medicine, there is no free lunch in medicine. Anything you put in your body that doesn't swim in the ocean, grow on the land, or fly in the air can be toxic to you over the long term.
Those are great points. And I totally agree with the structure. And so some of the things that I did just early on with this patient, and I should clarify. So I had said that when she first developed asthma symptoms, she was age 13, but when I saw her, she was 19. So this case is from when she was 19. But I think everything that's been said still applies. One of the first things we did was just to kind of reestablish like an approach, so short of whether a biologic would be good someday. And really we focused on her inhaled steroid because she had so much of the, kind of going back to today's talk, the T2 features and really underscoring to her the importance of that therapy and moving towards using it twice a day, which it ended up, I agree, a once daily would be even better. That wasn't a great option for her from an insurance coverage standpoint, but we really engaged on that. And I think ultimately she saw the benefit, but like her mom would say that when she used it, she wouldn't hear her at night. And then when she skipped it, she could tell a difference. And so over time we worked on that and we got much closer to good adherence, but it probably has never been exactly perfect. The other thing that I really wanted to mention was the juuling. So this, I've been seeing her for a couple years. The first time I saw her, she had come off of a prednisone course. So like we had talked about earlier, I think her EOs were actually not even where they ultimately were. And the second time I saw her, she had 45% eosinophils. So I had never seen that before. We've reported this case, and I ended up sending her to hematology to make sure she didn't have some kind of rare malignancy and so forth, which she didn't. And then she was very specific about juuling mango jewel. So we wondered whether she had an allergy to the mango in the jewel. And then we went to try to figure out what's in mango jewel. And a friend of mine who's an allergist, we went all over the place trying to figure out if there's actually mango in mango jewel. And I don't even think we ever answered that question. It's very hard to find out exactly what's in some of these. And this was a year ago or so. But that I did that. But it's very hard to figure out what's in these inhaled substances. And there's not a lot of regulation. And so that we think, and it trended over time that mango jewel was really, really a strong stimulus for her. The other thing that was really that I learned from this case is how hard it is to try to get someone to stop juuling who's highly addicted, or stop vaping, I should say. And she went to our smoking cessation clinic. We used nicotine patches. And I think probably also because of her depression and some of these other things, it was even harder for her to quit. And she still hasn't successfully quit. She's had periods of quitting, but most recently when I saw her, she came back from college and she was still sort of trying to quit. She and her boyfriend were trying to quit and they were down, but not off. So it's really hard. And people who are addicted to vaping or e-cigarettes, thinking about formal smoking cessation programs, or maybe they'll be renamed, is probably an important aspect of care. This patient really, yeah, go ahead.
Yeah, okay. Um, I noticed we mentioned this is a reproductive age young woman, and we also mentioned boyfriend, and we did not mention contraception in our list of medications. And even though I don't think we've broached this topic, the MABs, there are not concerns, there's just lack of information. We know that the MABs do cross the placenta in pregnancy. And if it was my patient and she's having unprotected sex and she has severe asthma, and I'm starting to cross that threshold about would this patient be a good candidate, I would want to inform her that we don't really know the outcomes of utilization of the biologics in pregnancy. Now, when I say we don't know the outcomes, what I mean is we don't have a randomized, double-blind, placebo-controlled Crosby, Stills, Nash, Young, Sears, and Roebuck trial to know what the answer is. There are pregnancy registries. And for those of you online who don't know this, I was very reassured. I had a woman who did not realize she was pregnant until she was slightly more than 8 weeks pregnant because her menses had been somewhat irregular in the past. And when she was pregnant, she had taken a medicine. I actually don't remember what medicine she had taken, but I called up the company that made the medicine. Every pharmaceutical company that makes a medicine keeps a pregnancy registry. They will say to you, well, thank you for informing us you had a patient who took this. We do not have a prospective trial, but if you would like to enter your patient's pregnancy outcome in the data set, we'd like to know the outcome, and we will also tell you the outcome of the women who have thus far reported their pregnancy outcomes. So it was very reassuring to my patient who took this medicine, and she felt guilty. She said, oh, how could I have been so insensitive? Or what if I did something to my unborn child? It was very reassuring to her in the absence of a trial that there had been like 175 women who had taken the same drug with no higher reported incidence of adverse outcomes in pregnancy than the general population. So for those of you who may not have been aware of that, that's a tool you always have. Now, there's one big downside. Industry will ask you to fill out a lengthy form. They're going to say, maybe now it's faster, it's electronically than when we had to do paperwork, because they want to know as much about your patient as possible. They don't consider it an adverse effect. It's not like when you report to them, my patient took drug XYZ and their leg fell off. No, they just want a lot of data so they can make their response to people who call up for answers more robust. So if a person says, well, all right, you told me that overall in pregnancy, there was no adverse effects. What about women over 35? I'm 35. So they'll ask you for a lot of data. You don't have to give it to them, but I'm sure you probably feel like I did, guilty if I did not, since I was asking them to do something for me.
Wonderful. So I think now would be great, Dr. McCormack, to just sort of give us a summary and update on what's happening now.
Sure. So she, as I said, she's kind of been intermittently successful stopping vaping, but unfortunately not completely. So I think that just demonstrates the addictive nature of vaping, and something to ask about too, separately, to make sure we're always asking about that when we're asking about smoking and inhaled substances. This, again, I think adherence is important for every asthma patient, whether they're mild to severe. So that was still something we're working on, adherence to her first line therapies. And I think there's been great discussion on some of the other components, really think in this patient, anxiety, depression, whether vocal cord dysfunction could be playing a role, the montelukast as part of her meds. And now I'm actually, over a year later, revisiting whether she would be a candidate for a biologic. And I haven't started her on that, but her EOs are still extraordinary, not to the 45, but she's well over 1,000. And so it's a work in progress, but I'm thinking now she may meet that severe, poorly controlled, and I'm still wrestling with really wanting her to be off vaping, but maybe we'll re-engage in that part of the conversation. Just, I think, a good example of how every patient doesn't always fit the textbook or the PowerPoint perfectly, but I think we had some great discussion. Thanks for everyone's contributions.
Thank you. Thanks, everyone. All right. Well, let's get to our housekeeping. We've got our post-test polling questions here. Question 1. Which of the following is the definition of an endotype? Is it the external observable characteristic of an organism resulting from interaction between its genetic makeup and environmental influences, or a distinct biological mechanism that is underlying a distinct disease entity? And question 2. Which of the following is not a biomarker for type 2 inflammation in asthma? Immunoglobulin E, IgE, eosinophil count, fractional exhaled NO, Fino, or interleukin 17? Thank you everyone for answering those, and we'll share them. Okay, Dr. McCormack, how'd they do?
So great. The overwhelming majority got the correct answer that endotype is a distinct biological mechanism underlying a distinct disease entity. And also that IL-17 is a biomarker of T1 rather than T2, and the others, IgE, eosinophil count, and exhaled NO, are all indicators of type 2 inflammation.
Excellent. Thank you so much. And then, of course, as always, just want to ask if anyone would like to share a patient case next week. Next week, we're talking about in depth about the biologic agents that we've been discussing here and there. So would anyone like to share a case? All right. Well, that's okay. I'm sure we'll have another wonderful case for you. I just want to say thank you everyone for joining us today. Echo clap. Thank you all so much, and we will see you next week. Have a good one. Bye-bye.